Right now, somewhere in the world, a brain is sending out a warning that will be ignored. Not because the person is careless, but because nobody ever taught them what that warning actually looks like. Stroke is one of the leading causes of death on this planet, and the single biggest cause of long-term adult disability. Those are sobering numbers. But here's the part. Almost nobody explains clearly. In a huge percentage of cases, the brain doesn't fail without notice. It gives a preview, a flash of something wrong that lasts only a few minutes, and then disappears completely. You feel fine again. You move on with your day, and 3 days later, the real event happens. Today, I want to walk you through exactly what those preview signals look like, why your body produces them in the first place, and what you actually have time to do about it. Because once you understand this, you stop being a person who's simply hoping nothing happens to you, and you become someone who can recognize the moment it matters most. Let's start with something most people get wrong from the very beginning: the two phases of stroke. When people hear the word stroke, they usually picture one single thing: someone collapsing suddenly out of nowhere. But medically, there are actually two very different events hiding under that one word, and the difference matters enormously. The first is called a hemorrhagic stroke. This is when a blood vessel inside the brain actually ruptures. Blood escapes into or around brain tissue, pressure builds, and that pressure itself causes damage on top of the loss of blood flow. It's less common, but when it happens, it tends to be severe. The second and far more common type is called an ischemic stroke. Here, nothing bursts. Instead, a vessel becomes blocked, usually by a clot or a fragment of fatty plaque, and blood simply stops reaching part of the brain. Roughly 8 or 9 out of every 10 strokes fall into this second category. So that's where we're going to spend most of our time today, because this is the type that tends to give warnings beforehand. To understand why a blockage is so devastating so quickly, you have to appreciate something most people never think about: how demanding your brain actually is to keep running. A hungry, relentless organ. Your brain weighs around 3 pounds. That's roughly 2% of your total body weight, and yet it consumes close to 20% of every breath of oxygen you take, and about a quarter of all the glucose circulating in your bloodstream at any given moment. Think about that ratio for a second: a small fraction of your body mass using a disproportionate share of your fuel supply. That tells you something important. Your brain has almost no reserve tank. It runs on a live, continuous feed, not stored energy. Cut that feed off, even briefly, and brain cells in the affected region begin dying within minutes. Not hours, minutes. That's why every stroke specialist will tell you the same thing in different words. Time is brain tissue. The faster blood flow is restored, the more of the brain can be saved. And that single fact is exactly why recognizing an early warning matters so much. Here's something most people never stop to consider. For an artery deep inside the brain to suddenly seal shut, the groundwork for that moment usually took years to build. The vessel wall didn't fail overnight. It was slowly injured, narrowed, and weakened long before the actual blockage occurred. This is not an explosion out of a clear sky. It's the final step of a long, mostly silent process. And along that road, your body very often tries to tell you something is wrong, using a brief, temporary preview of what a full stroke would feel like. The warning episode. Doctors take seriously. In medicine, this preview event has a name. It's called a transient ischemic attack, or TIA. The word transient is the key. It means temporary. It shows up and then it resolves completely, often within minutes. Here's a way to picture what's happening inside your body during one of these episodes. Imagine the main artery in your neck that carries blood up toward your brain. Over years, a layer of fatty plaque can build up along the inner wall, narrowing the space blood has to pass through. At some point, that already tight passage can briefly spasm, or a tiny clot fragment can lodge there for a few moments. Blood flow drops sharply to whatever part of the brain that vessel feeds, and that region essentially flickers off for a short window of time. You notice a symptom. Then the spasm relaxes, blood flow returns, the symptom fades, and you breathe a sigh of relief. What the research consistently shows is troubling. A transient ischemic attack very frequently precedes a major permanent stroke, often within the following 72 hours. Those 3 days represent a genuine window where serious damage can still be prevented. The problem is, almost nobody uses that window because the warning felt brief, strange, and then it simply went away. These episodes typically last somewhere between 30 seconds and 10 minutes. That short duration is exactly why they slip past unnoticed. You might be standing in your kitchen, stepping out of a car, or rinsing your hands. And by the time you've stopped to really process what just happened, the symptom is already gone. But each one of these moments is your body sending you a very specific message. I want you to think of a woman named Patricia for a moment. Not a real patient, just an illustration of how ordinary this can look. She was 61, healthy by her own description, and one afternoon while folding laundry, her right hand suddenly went numb and clumsy for about 90 seconds. She assumed she'd pinched a nerve reaching for the basket. She didn't mention it to anyone. 4 days later, that same hand stopped working completely, and so did the right side of her face. That sequence, a brief dismissed warning followed by a major event days later, is exactly the pattern doctors see again and again. So let's go through the 5 major red flags in detail. Not just what they look like, but what's actually happening inside the body each time, so you understand them well enough to never wave one away. Warning sign. 1. A sudden curtain over one eye picture. This. You're walking toward another room, and without warning, your vision in one eye goes dark or foggy, almost like someone pulled a thin curtain down over that eye, or smeared the lens with gray haze. You blink a few times. Within seconds to a minute, your sight returns to normal, and you blame it on standing up too quickly or too much screen time that day. In reality, that brief blackout is very often caused by a tiny clot or plaque fragment that broke loose from the neck artery, traveled upward, and briefly lodged in the small artery that feeds the retina, the light-sensing tissue at the back of your eye. That eye artery isn't some separate, isolated structure. It's a direct branch off the same internal artery that supplies blood to your brain. When that fragment clears and blood flow resumes, your vision returns, and you feel lucky. And you should, because that exact same fragment could just as easily have traveled a few millimeters further, into an artery feeding the brain instead of the eye. The difference between a 1-minute blackout in one eye and permanent loss of speech or movement can be a matter of which branch the clot happened to enter. Doctors have a specific term for this exact symptom, amaurosis fugax, which translates loosely to fleeting blindness. Neurologists treat that description like a fire alarm going off. If a patient reports an episode like this, it triggers urgent evaluation because the short-term risk of a full stroke afterward is genuinely elevated. Consider a man we'll call Amika, 68 years old. Over about 3 weeks, he experienced this exact symptom twice, a brief grayout in his left eye that cleared within a minute each time. He mentioned it to his wife, but assumed it was simply eye strain from reading. The third episode wasn't in his eye. It was a stroke affecting his speech and the right side of his body. His story is a near-perfect example of a pattern seen in hospital records over and over. People dismiss 2 or 3 of these eye episodes, and the next one is the major event. If you ever experience even a few seconds of vision loss in one eye that resolves on its own, that is never something to simply note and move past. It deserves a conversation with a doctor, and ideally soon, not eventually. Warning sign. 2. Numbness that has nothing to do with posture. The medical term here is paresthesia, but you can think of it more simply as a part of your body suddenly feeling drunk. It might be an entire arm, just a hand, half the face, or one full side of the body. People describe it as pins and needles, or like the limb has turned to rubber or cotton. The defining detail is that it appears completely out of nowhere, while you're simply sitting, walking, or talking, and then resolves within a few minutes on its own. Now, you've probably experienced ordinary numbness before. Falling asleep on your arm, waking up to find it tingling and useless until you shake it out. That's a compressed nerve, and it has nothing to do with your brain. The moment you move and blood flow normalizes in that limb, sensation returns. A TIA-related numbness is different in an important way. The problem isn't in the arm itself, it's in the specific patch of brain tissue responsible for sensing input from that arm, and the episode has nothing to do with how you were sitting or sleeping. One detail worth remembering. Stroke-related symptoms are almost always one-sided because each half of your brain controls and senses the opposite side of your body. If both hands go numb evenly at the same time, that more often points toward a neck or spine issue rather than a brain event. But sudden, one-sided numbness that comes and goes deserves to be taken seriously and discussed with a doctor, not filed away as must have slept on it wrong. If this is helping make sense of something that genuinely matters for your health, a quick like helps more people come across this video. And now, let's keep going, because the next two warning signs are ones almost nobody connects to stroke at all. Warning sign 3. The drunk walk. With no alcohol involved. This next one tends to surprise people because it doesn't look anything like the version of stroke shown in movies. Picture walking across a flat, completely familiar surface, and suddenly your foot lands in the wrong spot. Your leg feels weak or rubbery for a moment, or you stagger sideways into a wall. Or perhaps you're hit by a sudden, intense spinning sensation that makes you grab the nearest chair or door frame, even though you didn't move your head quickly and you weren't standing up from lying down. The part of your brain responsible for balance and smooth, coordinated movement is called the cerebellum. It sits low at the back of your skull, almost like a smaller secondary brain, and it's constantly calculating where your body is in space and exactly how hard each muscle should fire so that you walk in a straight line instead of veering. The cerebellum receives its blood supply through a set of arteries that travel up through the bones at the back of your neck. If blood flow through that pathway drops sharply, even briefly, the cerebellum essentially glitches. That's the moment you suddenly stagger, misstep, or feel violent, unexplained dizziness. In clinical experience, there's a recognizable pattern of people blaming these episodes on bad shoes, fatigue, or probably my blood pressure, only learning much later that those moments were actually warning episodes involving the cerebellum's blood supply. Ordinary, benign dizziness usually has an obvious trigger. Rolling over in bed, turning your head quickly, a known inner ear issue. But sudden, intense dizziness paired with real trouble walking straight should be treated as a possible warning sign until a doctor has ruled out a vascular cause. Think of a retired teacher named Folake, 73, who stood up from her garden chair one afternoon and felt the world tilt violently for about 40 seconds. She grabbed the fence, steadied herself, and the sensation passed completely. She told herself it was low blood sugar and made a sandwich. It happened twice more over the following 2 days before anyone in her family insisted she see a doctor. That insistence likely changed the outcome of her week. Warning sign 4. When speech suddenly breaks down. Before going further, I want to draw a clear line here, because this particular warning sign gets confused with something completely normal. If you occasionally can't recall your neighbor's name, or you briefly forget the word for toothbrush, that is not a stroke warning. That's an ordinary tip-of-the-tongue moment. And it happens more when you're tired or stressed. Almost everyone experiences it. What concerns neurologists is something distinctly different. A sudden breakdown in speech severe enough that even the person experiencing it senses something is seriously wrong. There are 2 key speech regions in most people's brains, usually located in the left hemisphere. One, often called Broca's area, helps you form words and send clear instructions to the muscles of your tongue, lips, and jaw. When blood flow to this region drops, you may understand everything being said to you and know exactly what you want to say back, but the words come out slurred, broken, or simply stuck. The other, often called Wernicke's area, helps you understand language and organize your own sentences so they make sense. When this region is affected, a person might speak fluently and confidently, but the words form nonsense, sometimes called word salad, and they may struggle to understand simple things said directly to them. If either of these speech disruptions appears suddenly and then fades within minutes, that pattern fits a transient ischemic attack, not ordinary tiredness. A self-correcting speech problem is not a reason to relax. It's closer to a home alarm going off, stopping on its own, and assuming it must have been a false alarm rather than checking the system. Warning sign 5. The combination. Almost no one connects. This last one tends to genuinely surprise people because on the surface, the 2 pieces seem completely unrelated. The first piece is a skin condition called vitiligo, patches of skin that lose their pigment because the cells responsible for color production stop functioning. Vitiligo is driven by an autoimmune process, meaning the immune system mistakenly attacks the body's own pigment-producing cells as though they were foreign invaders. Here's the connection most people never hear about. When the immune system goes off target like this, it frequently doesn't stop at just one tissue. In many people, that same misdirected immune activity can quietly inflame the inner lining of blood vessels as well. That lining is called the endothelium, an extraordinarily thin layer of cells coating the inside of every artery, functioning almost like a non-stick surface. When the endothelium is healthy, blood components glide through smoothly. When it's damaged by ongoing inflammation, it becomes rough and irregular, and things begin sticking to it. Cholesterol, platelets, inflammatory proteins, forming the early seeds of plaques and clots over time. Vitiligo on its own doesn't guarantee a stroke is coming. But when it's paired with new, unusually intense headaches that don't match your normal pattern, that specific combination deserves a real vascular evaluation rather than a let's just wait and see approach. It's worth pausing on headaches generally, because this is an area full of misconceptions. A very common cause of frequent head pain is simple wear and tear in the small joints of the upper neck, essentially arthritis affecting that area, which can irritate nearby nerves and refer pain up into the head, with absolutely no connection to a blocked artery. Many people also carry an undiagnosed disc issue in the neck that, left unaddressed, can eventually threaten nerve function in the arms. The point is, headaches shouldn't simply be numbed with medication indefinitely. They deserve to be properly understood with a doctor, especially when their character changes or they appear alongside any of the other warning signs we've covered. Have you experienced anything like this yourself? A strange, fleeting symptom you brushed off at the time? It's worth sitting with that question for a moment, because so many people watching this will recognize something from their own life in at least one of these 5 signs. The myth that puts people at ease for the wrong reasons. Now I want to talk about what actually damages blood vessels from the inside, because there's a widespread myth living right at the center of this conversation. The myth goes something like this: my cholesterol numbers are normal, so I'm not at risk. Stroke risk isn't just about what's floating around in your bloodstream. It's very much about the physical condition of that endothelial lining we just talked about. Go back to that non-stick surface idea for a second. While the coating is intact, very little clings to it. Once it's scratched and worn down, everything starts sticking and accumulating. The first major enemy of that lining is chronically elevated blood sugar. Glucose is fuel for your cells, but to actually get from your bloodstream into the cells lining your vessels, it needs insulin to open the door, so to speak. When your body doesn't produce enough insulin, or your cells become resistant to its effects, you can have abundant sugar in your blood, while the vessel lining cells themselves are essentially starving. Starving cells become damaged, lose their normal shape, and can even detach from the surface, leaving behind rough, scarred patches. Those scarred areas lose their ability to flex and adjust as blood pressure changes. What's sometimes described as a loss of vascular flexibility, and they become ideal landing zones for cholesterol particles, platelets, and other debris to accumulate into plaques. This entire process can be underway years before anyone is officially told they have diabetes. Even mild prediabetes, where blood sugar sits only slightly above normal, is enough to quietly injure that lining over time. The second major enemy is smoking. Cigarette smoke contains thousands of chemical compounds, and a number of them directly damage and inflame the inner surface of blood vessels with every single cigarette. At the same time, nicotine and carbon monoxide make blood thicker and stickier, increasing how easily platelets clump together and clots form. Combine a damaged, inflamed vessel wall with thick, sticky blood, and you've created close to ideal conditions for a clot to plug an artery in the brain. That combination is a major reason smokers face a meaningfully higher risk of ischemic stroke than non-smokers with similar cholesterol and blood pressure numbers. Blood pressure introduces a twist that confuses a lot of people, and it runs in the opposite direction from what they expect. Many people associate stroke purely with high blood pressure, so they feel reassured the moment a reading comes back low or normal. Chronically elevated blood pressure absolutely is one of the strongest risk factors for stroke over time because it physically stresses and weakens vessel walls and accelerates plaque formation. It's also the primary driver behind the hemorrhagic strokes we discussed earlier, where a vessel actually ruptures. But here's the twist. An ischemic stroke often happens not at the peak of blood pressure, but at a relative low point. Picture an artery already narrowed by plaque, like a garden hose pinched in the middle. As long as pressure in the system stays high enough, water still squeezes through that narrowed section. But if overall pressure drops, flow through that tight spot can fall to almost nothing, especially if a small clot happens to be sitting right there and there isn't enough force left to push it along. This matters more than people realize, because while you sleep, blood pressure naturally drops by somewhere around 15 to 20%. That's a completely normal, healthy nighttime pattern. But if you already have a narrowed artery, that ordinary nighttime dip can be just enough to turn a partial blockage into a complete stop, particularly if a clot has been quietly forming on that plaque while you slept. That's part of the explanation for something families describe again and again. Someone went to bed seemingly fine and woke up with stroke symptoms already in progress. Age changes the picture, but not the way you'd think. Age plays a real role here, but not in the oversimplified, stroke is only for elderly people way it gets discussed at family gatherings. Stroke risk does rise meaningfully after about 50 and continues climbing with each following decade. In older adults, the dominant drivers tend to be plaque buildup, long-standing high blood pressure, and heart rhythm irregularities. But a meaningful share of strokes, somewhere in the range of 1 in 10, happen in people under 45. In that younger group, the underlying causes often look different: inherited vessel abnormalities, weak bulging spots in vessel walls that can rupture, clotting disorders, autoimmune conditions, and trauma to the head or neck. There's another detail worth knowing. The same risk factors tend to cause vascular damage faster as you move through your 40s compared to your 30s. That accelerating pattern is a big part of why doctors tend to get noticeably more direct about risk factor control once patients reach their 40s and 50s. So here's something worth genuinely thinking about, not just hearing. How old are you right now, and which category of risk factors most likely applies to your specific situation? That single question shapes what conversation is actually worth having with your doctor. Before we move into what to actually do with all of this, I'd genuinely like to know where you're watching from today. Drop it in the comments below. I always enjoy seeing how far this reaches. What to actually do if you recognize one of these signs. Now for the most practical part of everything we've covered. Let's say you recognize one of those 5 warning signs from your own life, even if it lasted under 10 minutes and felt strange enough to dismiss. You're inside that roughly 72-hour window where meaningful prevention is still genuinely possible. The goal here isn't panic. It's using that window deliberately instead of letting it pass quietly. Stroke specialists frequently emphasize how important it is not to be completely alone following a suspected warning episode. This is genuinely worth planning ahead with family, especially if you live by yourself. If a more serious episode happens and you suddenly can't speak or move, you need someone nearby who can recognize it, call for help, and reach you quickly. Many people find it useful to simply tell a close friend or family member what happened and make sure someone can be reached easily over the following couple of days. That's a completely reasonable thing to raise directly with your doctor. Most guidance around suspected warning episodes also advises against driving yourself anywhere immediately afterward. Losing vision or arm control for even a few seconds at highway speed is dangerous for you and everyone else on the road. It's worth having a transportation plan discussed in advance with your doctor so you're never tempted to simply drive yourself somewhere in the moment. Checking blood pressure is typically among the first steps in almost any acute situation. If the top number, called systolic pressure, reads around 180 or higher, and the bottom number, diastolic pressure, reads around 110 or higher, that combination fits what's described as a hypertensive crisis, not simply elevated blood pressure. That kind of reading is itself considered a strong warning sign, and calling emergency services promptly is what standard guidance generally recommends. It's worth asking your own doctor directly about this threshold, so you know in advance exactly when to treat a reading as an emergency rather than something to monitor. One rule in stroke medicine is treated as essentially non-negotiable. Never start a blood-thinning medication like aspirin or any anticoagulant on your own, based on something a friend suggested or something you read somewhere. Remember, there are 2 fundamentally different types of stroke: blocked vessels and bleeding vessels. Thinning the blood can genuinely help in certain blocked vessel situations, but in a bleeding vessel event, it can make things considerably worse, faster. The only reliable way to distinguish between the two is brain imaging, typically a CT scan performed in a hospital setting. No one, however experienced, can determine which type is occurring just by observation without that scan. So instead of attempting to self-treat, the right move is always to get evaluated and let a medical team make that determination. It's entirely reasonable to ask your own doctor in advance how they'd want you to respond if you ever suspect this is happening to you. While waiting for help or on the way to receive care, body position can matter. Lying flat is generally considered better than sitting upright because it supports blood flow to the brain. Many clinicians suggest a comfortable flat position with the legs raised slightly above chest level to ease circulation and reduce strain on the heart. The head should remain in a neutral position, not bent sharply forward and not tilted far back so that the neck vessels aren't compressed. It's also sensible to avoid alcohol, smoking, or exposure to very hot baths or showers in that moment, since sudden vessel dilation during already unstable circulation can make things worse. As always, this is worth confirming directly with your own doctor ahead of time. One more detail that quietly saves precious time: keeping a written, easily accessible list of every medication you take regularly. In an emergency, that small piece of paper can meaningfully speed up the care you receive. Here's something many people misunderstand. If 72 hours pass and nothing further happens, that doesn't mean the danger has passed for good. It means you were given a genuine second chance, and that chance is still worth using. There are 3 specific evaluations that are entirely reasonable to bring up at your next medical visit, particularly if any of these 5 warning signs sound familiar from your own life. Each one examines a different piece of the overall picture. The first is a specialized imaging test called a carotid duplex ultrasound. Unlike a basic ultrasound that only shows the physical structure of the artery, duplex imaging also shows how blood is actually flowing through it, including whether that flow speeds up or becomes turbulent at a narrowed section. If the main neck artery is narrowed by roughly 70% or more due to plaque, that's described as a hemodynamically significant narrowing, meaning the blockage is severe enough to seriously limit blood flow. At that stage, the relevant question often shifts from "will a stroke ever happen?" to "when will it happen if nothing changes?" This is why surgeons sometimes recommend a procedure to physically remove that plaque buildup from the artery. It may sound dramatic, but in modern medical practice, it's a well-established, routine procedure that prevents a tremendous number of strokes every year. The second is a simple blood test called glycated hemoglobin, often abbreviated as HbA1c. This measures how much sugar has attached itself to your hemoglobin, the oxygen-carrying protein in red blood cells, over roughly the past 3 months, rather than capturing just a single morning snapshot the way a fasting glucose test does. It's particularly effective at catching that in-between zone called prediabetes, where blood sugar has been elevated long enough to quietly damage vessels, even though nobody has officially labeled it diabetes yet. Generally speaking, a result under about 5.7% is considered normal. A result between 5.7 and 6.4% suggests prediabetes, and 6.5% or above typically fits a diabetes diagnosis. If it's been years since your last test or you've never had one, that's a simple, low-effort thing to raise at your next appointment. The third is a 24-hour heart rhythm recording, sometimes called Holter monitoring. Rather than the brief 10 or 20-second heart tracing done in a typical clinic visit, you wear a small device for a full day while going about your normal routine. The reason this matters is that certain dangerous rhythm problems come and go unpredictably, sometimes appearing for only a few seconds at a time, and a brief snapshot test can miss them entirely. The single biggest rhythm-related culprit behind stroke is a condition called atrial fibrillation. In this condition, the heart's upper chambers stop beating in a coordinated rhythm and instead quiver chaotically. Blood doesn't empty smoothly from those chambers anymore. It swirls and churns instead, and within that swirling blood, clots can form surprisingly easily. Those clots can then travel from the heart up into the brain and lodge in an artery there, producing a particularly severe category of stroke. Many people living with this rhythm problem don't notice dramatic symptoms at all. At most, an occasional skipped beat or brief flutter that gets blamed on stress or caffeine. Holter monitoring is precisely the tool that catches these otherwise hidden episodes. And if this condition is identified, well-studied blood-thinning medications, properly prescribed and monitored, can meaningfully reduce the associated stroke risk. That's not simply something to worry about. It's something you and a cardiologist can actively work on together. Stepping back from all of this, a stroke is rarely a lightning bolt from a clear sky. It's typically a predictable event that follows years of quiet vessel damage, and very often, it announces itself in advance if you know what to watch for. You now know the major signals: brief blindness in one eye, sudden one-sided numbness or tingling, an unexplained loss of coordination or balance, a sudden breakdown in speech, and the less obvious combination of vitiligo paired with new, unusual headaches. Any one of these appearing for the first time, even if it resolves within a minute, is reason enough to raise it with a doctor soon, and to ask specifically about the 3 evaluations we just covered. On the prevention side, the research consistently points toward a handful of things genuinely worth your attention. Keeping blood sugar within a healthy range and catching prediabetes early protects that delicate vessel lining and slows plaque formation. Managing blood pressure thoughtfully with your doctor, rather than chasing the lowest possible number at all costs, reduces strain on your vessels and lowers both major categories of stroke risk. Stepping away from smoking, with real support if you need it, removes a constant chemical assault on your arteries and meaningfully reduces ischemic stroke risk over time. And above everything else, the single most important idea to carry with you: don't wait for a brief, strange symptom to simply go away on its own and assume that means it wasn't serious. In the world of stroke prevention, you genuinely have a window of roughly 72 hours where real action can still change the outcome. Here's what I'd encourage you to do after watching this. If anything we discussed today reminds you of something from your own life, even months ago, write it down in plain, simple language and bring that note to your next doctor's visit. Don't rely on memory alone in the moment. Ask directly whether you should be evaluated for a possible transient ischemic attack, and whether a carotid ultrasound, an HbA1c test, or Holter monitoring makes sense given your situation. If you carry risk factors like elevated blood sugar, high blood pressure, smoking history, or an autoimmune condition, use everything you've learned here to have a far more specific, productive conversation with your doctor instead of walking away with a vague, "everything looks fine," and no actual numbers behind it. Everything covered in this video is meant to help you understand your own body better, not to replace a real conversation with a medical professional who knows your specific history. Your situation is yours alone, and using what you've learned here as a starting point for that conversation will always serve you better than trying to manage it entirely on your own. I'm Dr. David Aid, and if this helped you see something in a clearer light today, consider subscribing. It genuinely helps more people come across information like this when they need it most. I'll see you in the next one.